Anyhow, I'm going to talk about Nataluzimab, progressive multifocal leukoencephalopathy. Those two words are tricky, so entertain yourselves at my different pronunciations. But they really represent the two sort of sides of advances in MS. I mean, Nataluzimab, as David Baker said, has really pushed forward treatment. It's twice as effective as interferons. The downside is there comes a price with these advances, and PML is a potential price we may have to pay for these very efficacious therapies. So what is PML? Well, it's a pathy, i.e. abnormality of the white matter of the brain, the encephalopathy. And it's progressive and multifocal. And I'm sure a lot of you will detect straight away it looks just like MS. It's in the white matter, and it's progressive, and it's in multifocal areas. But as you see from this scan and biopsy of the brain, is that it's actually much larger areas involved. It's much more aggressive looking in its formation. Its clinical presentation also has differences. Symptoms develop over weeks rather than months and years. There are other clinical differences in that it tends to affect personality, memory, and cognitive decline very early on. And unfortunately, this is why it can often go undetected for some time, because it's quite subtle initially. However, it does have other features such as limb weakness, imbalance, seizures, and speech impairment, which are more familiar to us. Now, PML has been around for a while. It's not a new disease. First described in 1958, and this is looking over case histories of patients. You'll notice that they have not MS, but different diseases. They have hematological diseases such as leukemia. They tend to present with deficits such as hemiparesis, poor concentration, clumsiness, but unfortunately it is in these patients with an underlying malignancy an inevitable decline in the condition. Now, the other difference between PML and MS is that we've actually discovered what causes it. And we've discovered that it's a virus, and this virus is called a JC virus, after the first person found to have it. It was noticed that in 1959 that there were inclusion bodies in the nuclei of the oligodendrocytes. That's part of the myelin in the brain, and inclusion bodies suggest that there's a virus. And then electron microscopy showed that there was these polymer-like particles, and then eventually in 1971 this was isolated in brain cells and labelled as a JC virus. So we now know what causes PML. And this is it. Very pretty virus structure. It's a double-stranded DNA structure. It means it has a strand of DNA, which makes it a living organism. This is how common JC virus is. So this is the seroprevalence, i.e. this means you've got antibodies in your blood. So this means that you have had exposure to it. This is the same with all the viruses, such as measles, mumps, and rubella, that you can check for people's exposure to it. And the BK virus is just a similar sort of polyoma virus. Now, you'll see here, this is the age, this is the percentage of positive antibodies. You'll see that pretty much by the age of 10, most people who are going to have been exposed to the JC virus would have done so. And that's probably true of most viruses. We pick them up in our young age at school. And the seroprevalence really increases very slightly over the years. So we probably pick up JC virus, and most of us, something between 60 to 80% of people, have all been exposed to JC virus. And this JC virus appears to stay in us. And this is true for all of us. We're all carrying around these viruses, not just JC, but they're in our body. In particular, they're in the bone marrow, in the kidney, they're excreted through our urine often, in the tonsils. We're not so sure whether they're always sitting in the brain or the gut. And this is something we need to establish.